Have you ever gone down one of those medical WebMD rabbit holes and just absolutely terrified yourself?
Oh, yeah, constantly.
Right. Like you start by looking up a totally common symptom, maybe a headache or I don't know, a weird twitch in your eye.
Yeah, and 30 minutes later, you're staring at a screen, utterly convinced you have this, like, incredibly rare, completely incurable disease.
Exactly. You know the feeling. Well, today's deep dive is really about pulling you out of that exact rabbit hole.
Because, the internet gives us access to every statistical worst-case scenario instantly, but it completely strips away the clinical context.
Right. The context you need to actually understand the probabilities.
Exactly. It's so easy to see a terrifying number and just, well, assume the absolute worst.
Which brings us to the clinical excerpts we are diving into today. They cover migraine catasol and rare vascular stroke syndromes.
Which sounds incredibly intense.
It does. And buried in these medical texts is this scenario that feels just universally relatable. So a patient's daughter calls her doctor in an absolute panic. She's had migraines with visual auras since her 20s. Just a standard annoying part of her life.
Yeah, very common.
But she just read an article online linking migraines to strokes, and now she is, like, bracing for the end.
And I mean, it makes sense why she'd panic. While rare vascular diseases can sound profoundly frightening on paper, understanding the mechanical realities behind them actually gives us power.
Okay, let's unpack this. The mission of this deep dive is to explore these rare, sort of rule-breaking vascular disorders, right?
Yeah.
To extract the real aha moments from the medical text, and honestly to separate unwarranted fear from proportionate caution.
Right, because when you know how the plumbing of the human body actually works, you replace panic with context.
Yes, exactly. So looking at the daughter's fear, the sources do actually acknowledge a non-random association between migraines and strokes, particularly in young women.
Yeah, it is a documented association. The data shows that having a migraine with an aura raises a person's stroke risk by roughly 108%.
Wow.
And a migraine without an aura raises it by about 25%.
See, if you stop reading right there, 108% sounds like a massive, terrifying number. It sounds like a coin flip.
It really does.
But I want to push back on the scariness of that stat because it's deeply misleading if you don't look at the baseline.
Right, the baseline risk is key here.
Think of it like this. If your chances of winning a terrible lottery are 1 in a million, a 108% increase just makes it roughly 2 in a million.
Exactly.
You are doubling a tiny number. So at the end of the day, you're still left with a tiny number.
Yeah, the absolute risk remains incredibly small. And on top of that, the source provides a mechanical reassurance that should really lower the blood pressure of anyone listening who suffers from migraines.
Oh, what's that?
The risk of a hemorrhagic stroke, meaning, a blood vessel bursting and bleeding into the brain, is not increased at all by migraines.
Oh, wow, not at all.
Not at all. The modest risk increase is entirely tied to ischemic events, which are blockages. So ordinary migraines, without any other red flags, just do not warrant sounding the alarm.
Okay, that is a huge relief. But the sources also describe something called a migrainous infarction, which to me implies the migraine itself acts as the trigger that causes the stroke.
Right, rather than the two just happening to occur at the same time.
Yeah, mechanically, how does a doctor even distinguish that?
Well, what's fascinating here is how rigorous the diagnostic criteria are to prove a migraine actually caused an infarction.
They don't just assume it.
No, absolutely not. It is a strict diagnosis of exclusion. A physician has to systematically hunt down and eliminate every other potential structural or cardiovascular cause before they can blame the migraine.
That makes sense. And the symptom timeline seems to be the biggest gatekeeper, right?
Yeah, timeline is everything.
Because a normal aura might last, what, an hour? For a migrainous infarction, the sources state one or more of the patient's typical aura symptoms must persist for more than 7 days.
Yes, more than 7 days without fully reversing.
That is a very long aura.
Well, because a standard aura is essentially a wave of electrical and chemical activity moving across the surface of the brain. It resolves.
Right.
But an infarction means actual tissue death from a lack of blood flow. If the symptoms last a week, it indicates structural damage, not just an electrical wave.
Plus, neuroimaging actually has to visibly confirm a stroke in the brain.
Exactly. And it usually happens in a specific neighborhood of the brain.
The text notes this typically occurs in the posterior cerebral artery distribution, right? the PCA.
Right, that's the blood vessels supplying the visual processing centers at the back of the brain.
So this presents as a throbbing headache with, like, stereotyped visual phenomena in both eyes, but the vision loss eventually becomes permanent.
Yeah, it's not just a bad headache that ruins your afternoon. It requires a perfect storm of criteria to meet that definition.
So bringing it back to the terrified daughter, or, anyone listening who deals with migraines with aura, what is the actual actionable takeaway here?
Proportionate caution.
Hmm.
I mean, it is a real risk factor,
Yeah.
so you should absolutely mention it to your physician.
Right.
But the mechanical compounding factors are where you actually have control. Like if you smoke or if you use estrogen-containing contraception,
Those compound the risk?
dramatically. Those elements chemically interact with your blood vessels to multiply that baseline risk.
Right, you take that tiny baseline and you start multiplying it with nicotine and synthetic estrogen, and suddenly the number isn't so tiny anymore.
Exactly.
So the takeaway is to drop the cigarettes, evaluate your birth control options with your doctor, and just stop agonizing over the baseline statistic.
That's the best approach. However, the sources also pivot to situations where a migraine isn't just an electrical anomaly, but rather an early warning siren for a structural collapse.
Uh-oh.
Yeah, this introduces the concept of a clinical mismatch.
The mismatch concept completely changes how you look at a diagnosis. Walk us through that.
Sure. So imagine a young patient with a history of migraines who gets a routine MRI. The scan reveals early white matter changes in the brain.
Which is essentially scarring in the deeper tissues, right?
Right. But this patient doesn't have high blood pressure, they don't have diabetes, and they aren't elderly.
So the physical wear and tear in the brain entirely mismatches their age and risk profile?
Exactly. The plumbing looks like it belongs to an 80-year-old with a lifetime of poor vascular health, but the patient is a healthy 35-year-old.
That mismatch forces doctors to, like, abandon the standard playbook and look for genetic rule breakers, which leads us to CADASIL.
Yes, CADASIL stands for Cerebral Autosomal Dominant Arteriopathy with subcortical infarcts and leukoencephalopathy.
Okay, let's translate that into plain English for everyone listening.
Probably a good idea.
It's basically a genetic disease inherited from a parent that systematically destroys the small blood vessels deep inside the brain.
Yes, and the sources pinpoint the exact culprit, which is a mutation in the Notch3 gene on chromosome 19.
Notch 3. Got it. And the progression of this is pretty brutal, right?
It is relentless. It frequently begins with those migraines with aura we were just discussing.
Great, the early warning siren.
Exactly. But then, as the patient reaches mid-adulthood, the damaged vessels start causing recurrent subcortical ischemic strokes.
Tiny blockages deep in the brain.
Yes. Over time, this cumulative damage leads to pseudobilbar palsy, which is a loss of control over the muscles in the face and mouth, severe cognitive decline, and ultimately subcortical dementia.
And there's even a subvariant mentioned, CADASIL, where the M stands for migraine, right?
Yeah, that variant is defined by a particularly high, almost brutal frequency of migraine attacks before the strokes even begin.
But the mechanism behind why these blood vessels fail, here's where it gets really interesting. The mutated Notch3 gene causes a weird granular osmophilic material to build up inside the arterial walls.
It physically alters the architecture of the blood vessels.
Think of that granular material like pouring liquid concrete down a flexible rubber hose.
That's a great analogy.
As it coats the inside and hardens, the hose loses its ability to flex, it narrows, and eventually it just cracks.
Exactly. And you would assume that to diagnose a disease destroying arteries deep inside the brain, you'd have to, drill into the skull for a biopsy.
Right, but you don't.
You don't. Because this is a genetic mutation, every single cell in the body carries the faulty instructions.
So that liquid concrete isn't just being poured into the brain's plumbing?
No, it's being deposited in small arteries systemically, including the germinal arteries in the skin.
Meaning a doctor can take a simple skin biopsy from your arm, look at the tiny blood vessels in that sample, spot the concrete-like buildup, and diagnose a degenerative brain disease.
It's amazing, right?
It's like figuring out the wiring in your attic is faulty by just unscrewing a light switch in the living room.
It's a brilliant diagnostic shortcut.
Right.
But sadly, the therapeutic reality of CADASIL is far less elegant.
Right. The sources detail a clinical trial using a drug called Dunpezil for CADASIL patients.
Yeah, they were testing it on patients suffering from vascular cognitive impairment. The goal was to see if it could improve their overall cognition.
And the results were, well, honestly, largely disappointing, weren't they?
Very. There was no improvement in general cognition. It offered a slight bump in specific executive functions, like processing speed and attention, but it doesn't stop the concrete from building up in the pipes.
It highlights a frustrating truth in neurology. We are often much better at diagnosing the mechanics of a rare disease than we are at actually halting them.
Definitely. Catasil demonstrates how a genetic glitch can hijack the vascular system, but it is just one of several genetic rule breakers the sources outline.
So let's look at the broader checklist of these rare vasculopathies. Reading through the source material, it felt like a random table of contents at first, just a list of terrifying, obscure diseases.
It can definitely read that way.
But if you look closely at the mechanisms, you can actually group them. Let's start with the diseases where the body's internal environment becomes toxic to its own plumbing.
Okay, a prime example of that is Fabry disease. It's an X-linked genetic condition where the body lacks a specific enzyme called alpha-galactosidase.
And enzymes are basically the cellular waste disposal system, right?
Essentially, yes. When you lack this one, metabolic waste products, specifically a type of fat, start piling up inside the cells that line the blood vessels.
So the pipes are literally becoming engorged with garbage until they bulge and fail.
Exactly. This causes painful neuropathy and kidney disease, but the physical clue for doctors is wild. The sources mention angiokeratoma corporis diffusum.
Say that 3 times fast. What does that actually look like?
It translates to dark red and blue spots clustering on the skin, specifically between the belly button and the knees.
Oh, wow. Why there?
Well, the waste buildup causes tiny blood vessels near the surface of the skin to dilate and become visible. So if a physician sees those specific spots on a young patient having a stroke, the mechanical link points straight to Fabry disease.
That is incredible. Then there is homocystinuria, another metabolic failure. But instead of fat piling up, homocysteine accumulates in the blood because of enzyme deficiencies.
Right. And homocysteine acts like a chemical abrasive. It aggressively damages the endothelium, which is the delicate inner lining of the blood vessels.
It's like pumping liquid sandpaper through the arteries.
Yeah. And the body responds to this constant scraping by trying to patch the damage, which leads to premature atherosclerosis and a massive tendency for the blood to clot.
And the physical clues here are a tall, slender, or marfanoid build, and bizarrely, lenses in the eyes that physically dislocate.
If we connect this to the bigger picture, these metabolic diseases show us that the body is an intricately connected map.
In what way?
Well, the failure of a microscopic enzyme creates a toxic environment that dislocates the lens of an eye and triggers a stroke in the brain. They're all tied together.
Right. Now let's look at the other group of rule breakers. These aren't cases where the environment is toxic. These are cases where the pipes themselves are built out of faulty materials. You mentioned a marfanoid build just a second ago, which leads us directly into Marfan syndrome.
Right. Marfan syndrome involves a defect in fibrillin, which is a structural protein. It's essentially the scaffolding that gives connective tissue its strength and elasticity.
The immediate danger most people know about with Marfan is aortic root dilation, where the main blood vessel leaving the heart just bulges.
Right, but the sources highlight how this threatens the brain too.
How so?
When that scaffolding is weak, the high-pressure blood leaving the heart can cause a dissection. It physically tears the inner layers of the aortic wall apart, which can cut off blood flow to the brain, spinal cord, and peripheral nerves instantly.
Terrifying. And an even more extreme version of faulty materials is Ehlers-Danlos type 4, right?
Oh, absolutely. The genetic mutation here results in profound vascular fragility. The blood vessels are paper-thin and incredibly delicate.
Making aneurysms and spontaneous dissections just a constant threat.
Yeah. And there is a massive warning in the sources about treating these patients.
Yes. The medical pearl about arteriography. Normally, if a doctor wants to see what's wrong with a blood vessel, they perform an arteriography. They thread a catheter wire into the artery and inject dye.
Right, it's standard procedure. But for an Ehlers-Danlos type IV patient, that diagnostic tool becomes a weapon.
Because the vessels are too fragile.
Exactly. The physical pressure of the dye injection or just the friction of the catheter wire itself can literally rupture the fragile artery from the inside.
Oh, wow.
Arteriography has to be actively avoided here. The attempt to view the damage will often cause a fatal tear.
It fundamentally changes the rules of medicine when the diagnostic test is the very thing that destroys the patient.
It really does.
So we've covered toxic environments and weak materials. But the sources then shift to a category that is just bizarre.
Yeah, obscure syndromes and embolisms that take strange pathways.
Let's examine how clots can bypass the body's natural defenses. Hereditary hemorrhagic telangiectasia, or HHT, is a perfect mechanical example.
Yeah, it causes a paradoxical embolism.
Normally, a blood clot that forms in a vein, say in your leg, travels up to the lungs where it gets trapped in the dense filter of microscopic capillary.
Right, which causes a pulmonary embolism. It's bad, but it doesn't reach the brain.
So how does a paradoxical embolism happen in HHT?
Well, HHT causes pulmonary arteriovenous malformations. These are abnormal, tangled connections between arteries and veins in the lungs.
So they effectively act as massive bypass tunnels.
Yes, exactly. A clot travels from the leg, hits the lung, but instead of getting caught in the capillary filter, it slips right through one of these bypass tunnels.
And enters the arterial circulation.
Right, and it shoots straight up to the brain. The filter is bypassed entirely.
Wow. Then there are these autoimmune mysteries like Susak syndrome. The sources describe this occurring primarily in adult women.
Yeah, and it features a very striking triad of symptoms.
Encephalopathy, which is severe brain dysfunction branch retinal artery occlusions causing vision loss and hearing loss. Brain, eyes, and ears all failing at once.
The mechanism explains the triad, though. Susak syndrome is an autoimmune attack, specifically targeting the endothelium of incredibly tiny blood vessels.
So because the brain, the retina, and the inner ear all rely on highly specialized microscopic microvasculature.
Exactly. When the immune system attacks those specific tiny vessels, all three organs suffer microstroke simultaneously. The MRI pattern actually favors the central fibers of the corpus callosum.
Fascinating. You also have Sneddon syndrome, which is characterized by a lace-like purplish skin discoloration called levato reticularis, paired with strokes.
Right, and it's linked to antiphospholipid antibodies, which essentially make the blood dangerously sticky, prone to clotting in small vessels.
And we should quickly mention reversible cerebral vasoconstriction syndrome, or RCVS. Patients experience these explosive, sudden thunderclap headaches.
Yeah, mechanically, the arteries in the brain are spontaneously spasming and clamping shut, restricting blood flow.
And this hyperactivity of the blood vessels is strongly linked to vasoactive drugs, right? As well as extreme hypertension and the postpartum period. And briefly touching on cerebral amyloid angiopathy, it's usually known for causing bleeding in the lobes of the brain because amyloid proteins make the vessels brittle.
Right, but the sources note it also raises the risk of blockages, specifically in Alzheimer's patients. So the pipes can either crack and bleed, or they can clog.
Which brings us to the final critical mechanism from the sources, embolisms that have absolutely nothing to do with blood clots.
Yeah, when we hear stroke, we automatically think of a blood clot from the heart. But debris can take many forms.
A fat embolism is a prime example. If someone suffers a massive trauma, like breaking a femur, the bone marrow, which is rich in fat, can literally escape into the torn veins.
It's terrifying. That fat globule travels through the bloodstream, leading to breathing difficulties, confusion, and a rash of tiny bleeding spots under the skin called petechia.
Usually within days of the fracture, right?
Right. There's also the amniotic fluid embolism, where fluid surrounding a fetus enters the mother's bloodstream, a rare, often catastrophic systemic shock during delivery.
Or an air embolism, which is a feared complication during central line placements or brain surgeries performed with the patient sitting upright.
Yeah, if a vein is open and the pressure drops, air is sucked directly into the bloodstream.
An air bubble acts just like a solid clot, blocking blood flow. The sources note the immediate mechanical fix for this is wild.
What do?
You place the patient on their left side with their head down to try and trap the air in the heart and use hyperbaric oxygen to shrink the bubble.
Wow. But the most counterintuitive mechanism the sources highlight involves thermomatous cholesterol embolization.
Commonly known as blue toe syndrome.
Yes.
This usually happens after a medical procedure where a severely diseased aorta is physically manipulated by a catheter or surgical instruments. Right?
Exactly. Plaques of cholesterol in the vessel wall break off, shatter into tiny pieces, and shower down the arterial tree.
And they lodge in the small vessels of the feet, literally turning the toes blue. So what does this all mean for the physician actually treating it?
This raises an important question, because the autopilot response in medicine can sometimes be fatal here.
Fatal? How?
When a doctor diagnoses an embolism causing blockages, the immediate instinct is to prescribe blood thinners to start anticoagulation therapy.
Right, because if it's a blood clot, you want to thin the blood to stop it from growing.
Exactly. But in cholesterol embolization syndrome, the blockage isn't a blood clot, it's a physical chunk of cholesterol plaque. If you reflexively give that patient anticoagulants, you thin their blood, which can actually loosen the biological glue holding the remaining claques to the diseased aortic wall.
Oh, wow. You essentially cause a landslide.
Yes.
By giving blood thinners, you dislodge even more cholesterol debris, massively worsening the shower of emboli.
Giving blood thinners just because the chart says embolism will actively harm or kill the patient. It proves that understanding the precise mechanism, the why and the how, is the only way to safely navigate these rare syndromes.
The standard rules just do not apply. We have covered a massive amount of clinical ground today. Let's do a rapid-fire 30-second wrap-up of the most crucial mechanisms we've extracted from these sources.
Okay, number 1. Migraine with aura doubles ischemic stroke risk, but has zero effect on hemorrhagic risk.
Number 2. Catadicil is a genetic mutation in the Notch3 gene that deposits concrete-like material in small arteries, causing migraines, subcortical strokes, and early white matter changes. And famously, you can spot it with a skin biopsy.
Number 3. A migrainous infarction requires the aura symptoms to last more than 7 days with visible structural brain damage on an MRI. It is a strict diagnosis of exclusion.
And finally, reflexively giving blood thinners for Blue Toe syndrome will unleash a landslide of cholesterol plaques and make the condition dramatically worse.
Perfectly summarized.
So let's bring this all the way back to you, the listener, and back to that terrified daughter who went down the internet rabbit hole at the start of our deep dive.
Right. Her story, grounded in the reality of the sources, ends with genuine reassurance.
It does. Her migraine pattern resolved normally. There were no red flags of a prolonged infarction.
There was no family history of early dementia or systemic strokes suggesting a Notch3 mutation either.
So the clinical recommendation for her was incredibly sensible. Avoid smoking and rethink estrogen contraception.
Because those are the mechanical levers that actually compound her baseline risk.
Exactly. The ultimate takeaway for you. Proportionate caution. The goal of understanding Fabry or Catadicil or paradoxical embolisms isn't to make you hyperventilate over every headache or weird skin blemish.
No, it's to show you that even when diseases break the rules, the human body operates on logic. When you understand the mechanics, knowledge gives you power over panic.
You realize the diagnostic landscape isn't random, it's just a highly complex puzzle of interconnected plumbing and proteins.
Exactly.
But I want to leave you with a final provocative thought to mull over, one that builds on the incredible interconnectedness we explored today.
I like where this is going.
Given how many of these rare stroke syndromes are intrinsically tied to genetic connective tissue and skin disorders, we talked about Marfan, Fabry, Ehlers-Danlos, Catadicil, could the future of stroke prevention lie entirely outside the brain?
That is fascinating to think about.
Right. Imagine a world where preventing a devastating neurological stroke doesn't involve treating the blood vessels at all. Imagine if, instead, we use CRISPR gene editing to fix the underlying proteins that build our skin, our cartilage, and our cellular waste systems.
Because if the root cause is a systemic structural protein, correcting that protein at the genetic level could theoretically eliminate the vascular fragility entirely.
You wouldn't need dangerous arteriograms or a lifetime of blood thinners. You could cure a brain stroke risk by fixing the skin.
It completely shifts how we view the boundaries of the human body.
It really does. So the next time you feel a headache coming on, step away from the search bar. The mysteries might be deep, but the mechanics are always there, waiting to be understood.